Welcome to our first video on pediatric urology. Let's begin. In this lecture, we're going to discuss testicular conditions including cryptorchidism and Uretero-urethral conditions, including Vesicoureteral Reflux and Posterior Urethral valves. Let's start with cryptorchidism. Cryptorchidism is the most common congenital urogenital tract anomaly where one or both testicles fail to descend fully into the scrotum. The most notable risk factors for cryptorchidism include prematurity, low birth weight, diethylstilbestrol exposure in utero, and being small for gestational age. Clinical features include failure to palpate the testicle in the scrotum, hypoplastic scrotum, and decreased rugation of the scrotum. Inguinal fullness may be present depending on the position of the undescended testes. There are multiple locations that the testes may stop at while descending from the abdomen. For example, the testicle can get stuck at the abdominal or inguinal region. This is an image that shows the pathway of normal descent of the testicle. As we can see on the far left, when the testicle first develops, it is located high up near the kidneys, in its starting position in the abdomen. From there, chemical and hormonal signals cause it to descend. The gubernaculum is a band that attaches from the scrotum to the testicle and helps guide the testicle along its path of descent. It descends through the inguinal canal to its final position in the scrotum. A single or both testicles can fail to descend anywhere along the pathway. So these red circles represent the many places a testicle can get stuck on its journey to the scrotum. These can be abdominal, inguinal, or suprascrotal. The diagnosis is mostly clinical. Laboratory results may show decreased testosterone if cryptorchidism is bilateral. If it's unilateral, the testosterone will be normal. Cryptorchidism usually resolves spontaneously by age 4 to 6 months. If it doesn't resolve by then, orchidopexy should be performed before age of 1 to prevent complications. Orchidopexy is a surgical procedure done to move the undescended testicle to its normal place in the scrotum and fixate it there. Complications of untreated cryptorchidism include infertility, subfertility, testicular cancer, testicular torsion, and inguinal hernia. Alright, now let's solve this question. A 6-month-old boy is brought to the physician for a well child examination. He is at the 60th percentile for length and 70th percentile for weight. On physical exam, only one testicle is palpated in the scrotum, but the examination is otherwise normal. What is the recommended treatment for this patient's condition? So this 6-month-old boy is presenting with cryptorchidism. Since he's 6 months old, orchidopexy is the recommended treatment because spontaneous descent of the testes is very unlikely after this age. Orchidopexy will prevent complications such as infertility and testicular cancer and should be performed before the age of 1 year. Alright, next, let's discuss vesicoureteral reflux. Here's a list of topics we'll discuss for vesicoureteral reflux. Let's start with some general information. Vesicoureteral reflux is a condition where there is a retrograde flow of urine from the bladder into the ureters. It affects more girls than boys with a ratio of 2 to 1. This condition can either be primary, which is more common, or secondary. In primary cases, the ureters have a short intramural part. This is the part of the ureters that run through the wall of the bladder. Let's take a look at this image. Here we can see the intramural part of the ureters running through the bladder wall. When this part is short, the reflux of urine may occur from the bladder into the ureters. Secondary etiologies of VUR include bladder outlet obstruction, for example, due to posterior urethral valves, urethral meatal stenosis, or neurogenic bladder, congenital ureteral anomalies, or it can also be iatrogenic, post-surgery. Children with VUR present prenatally with hyponephrosis or oligohydramnios detected on routine prenatal ultrasound. Postnatally, children may be asymptomatic or can have recurrent UTIs with fever and irritability, especially in neonates, urgency, frequency, and dysuria in older children, as well as flank or abdominal pain. Complications of VUR include nephropathy due to interstitial nephritis, hypertension, kidney failure, and renal scarring. Upper urinary tract infections can also lead to urosepsis. Laboratory examination with urinalysis and urine culture is important to look for infections. Renal function tests with serial creatinine and urea are required to look for evidence of reflux nephropathy. On complete blood count, anemia can indicate chronic kidney disease, and leukocytosis can indicate urosepsis. VUR is initially suspected in children with antenatal ultrasound showing evidence of hydronephrosis. If not suspected prenatally, a postnatal ultrasound should be performed in all patients with febrile UTI, which may show evidence of hydronephrosis, especially in advanced stages. Ultrasound is also used for follow-up. Contrast voiding cystourethrogram is performed and can measure the reflux of urine from the bladder into the ureters during micturition. It also classifies the severity of the reflux into grades from 1 to 5. Here is an image illustrating grades 1 through 5 of VUR. As we can see, the higher grade of the reflux, the higher the severity of condition. In grade 1, the reflux is limited to the ureter. In grade 2, the reflux reaches up to the renal pelvis. In grade 3, the reflux reaches up to the renal pelvis and there is mild blunting of the renal calyces. In grade 4, there is gross dilation of the ureter. In grade 5, there is significant dilation of the ureter, pelvis, and calyces. In grades 1 to 2, no hydronephrosis is present. In grades 3 to 5, hydronephrosis is present. Here is a diagnostic approach that can be helpful in determining the next step of diagnosis in children suspected of VUR. When a child less than 2 years old comes in with febrile UTI, and they have a history of previous febrile UTI, then voiding cystourethrogram is recommended. However, if this is their first febrile UTI, the next step should be to perform renal and pelvic ultrasound. If that initial ultrasound was abnormal, the next step is to also perform a voiding cystourethrogram. If the ultrasound is normal, 3 things must be assessed. First, is the patient's temperature higher than 39 degrees Celsius and another pathogen has been detected on urine culture other than E. coli? Second, is the patient hypertensive, which could indicate kidney involvement? And third, has the patient been growing poorly? If any of these are present, then a voiding cystourethrogram should be performed. If none of these are present, it's the first febrile UTI and the ultrasound was normal, no further diagnostic method is required. Before I go any further, I'd like to mention this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of VUR. Here's an image of a voiding cystourethrogram showing unilateral VUR. We can see here the contrast refluxing from the bladder into the right ureter. There seems to be no ureteral dilation. Here's another image of a voiding cystourethrogram showing bilateral VUR. Note the contrast in both the ureters reaching to the pelvicalyceal system. Initial management of VUR involves treating the infection. Patients with low risk of pyelonephritis and renal scarring, for example, children less than 5 years of age with grades 1 to 3, are treated with long-term prophylactic antibiotics and close monitoring with urinalysis and renal imaging. Patients with high risk, for example, patients with grades 4 to 5, bilateral VUR, and patients with refractory disease despite treatment need surgery. Surgery with ureteral transplantation can be performed, which corrects the reflux and has a very high success rate. Finally, because recurrent or chronic VUR can cause renal scarring, renal scintigraphy with dimer captosuccinic acid is used for long-term evaluation of renal scarring. All right, now let's solve this question. A 15-month-old girl is brought to the physician due to irritability and fever. Her mother says she cried every time she passed urine for the past 2 days. She was treated for a urinary tract infection 4 months ago, but is otherwise healthy. A renal ultrasound shows hydronephrosis on the right kidney. What is the best next step in managing this patient? So this 15-month-old girl is presenting with signs and symptoms of an upper urinary tract infection, such as irritability, fever, and crying while passing urine. She has been treated for a previous UTI, so this is a recurrent infection. This, along with a renal ultrasound showing hydronephrosis, makes vesicoureteral reflux the most likely diagnosis. Therefore, avoiding cystourethography is the best next step. It will measure the reflux of urine from the bladder into the ureters during micturition and will classify the severity of the reflux into grades from 1 through 5. All right, let's next discuss posterior urethral valves. This is a congenital anomaly in boys where membranous folds obstruct urinary flow in the distal prostatic urethra. The distal prostatic urethra is also referred to as the posterior urethra. In posterior urethral valves, a membrane obstructs the outflow of urine from the posterior urethra, hence the name. When urine outflow is obstructed, urine builds up in the bladder and backs up into the ureters, causing progressive bladder dilation and ureteral dilation, which eventually leads to hydronephrosis and progressive kidney disease. This condition is considered to be the most common cause of urinary bladder obstruction in newborn males. If we take a look at this image again, this is where the posterior urethral valve can be found. So let's take a look at the clinical features. Because posterior urethral valves can cause kidney problems in utero, oligohydramnios can occur, which will manifest in what is referred to as Potter sequence. This sequence comprises the presence of flat facies, pulmonary hypoplasia, and limb deformities. Because of the oligohydramnios, the baby is compressed, hence the flat facies and limb deformities. The lack of amniotic fluid also causes pulmonary hypoplasia, as the fetus relies on breathing it for lung development and expansion. Therefore, some newborns with posterior urethral valves will present with respiratory distress upon birth. Here's an image of Potter sequence showing flat facies and limb deformities. Remember, this occurs due to oligohydramnios in utero. Continuing with clinical features, abdominal distension may be present due to urinary bladder distension. Infants will have voiding problems such as straining and poor urinary stream due to the urethral obstruction. The urinary buildup in the bladder will increase the intravesicular pressure and Vesicoureteral reflux will occur. VUR is a condition where there is retrograde flow of urine from the bladder into the ureters. Urinary stasis will also lead to urinary tract infections, which may progress to urosepsis. VUR and kidney infections can lead to chronic kidney disease and eventually renal failure. Infants can also present with failure to thrive due to chronic kidney disease. Ideally, posterior urethral valves are diagnosed prenatally on routine prenatal ultrasound. Postnatally, the method of choice for diagnosing posterior urethral valves is voiding cystourethrogram, where dilation of the prostatic urethra will be evident. On ultrasound, a thick dilated bladder and bilateral hydronephrosis are characteristic. The first-line treatment for posterior urethral valves is valve ablation, which relieves the obstruction and allows urine to flow from the bladder to the urethra. Here is an image showing subvesicular obstruction by urethral valve. Here we can see the obstructing valve, the dilated bladder, and vesicoureteral reflux with dilated ureter. Notice the weak urine stream after the obstruction. All right, now let's solve this question. A 10-day-old newborn boy is being evaluated for a high fever, irritability, and lack of feeding for 2 days. Pregnancy was complicated with oligohydramnios. On physical exam, his abdomen appears distended and a urine stream is weak. What is the method of choice to confirm the diagnosis? This 10-day-old newborn boy is presenting with high fever, irritability, lack of feeding, and signs of urinary tract infection. Oligohydramnios, distended abdomen, and weak urinary stream are all characteristic of posterior urethral valve. Posterior urethral valves is the most common cause of urinary tract obstruction in newborn males. On ultrasound, a thick, dilated bladder and bilateral hydronephrosis are characteristic. The method of choice for diagnosing posterior urethral valves is voiding cystourethrogram. On voiding cystourethrogram, dilation of the prostatic urethra can be evident. A newborn male is being evaluated in the delivery room for a weak cry, irregular breathing, and respiratory distress. His pulse oximetry shows an oxygen saturation of 76%. The pregnancy was complicated by oligohydramnios. Physical exam reveals facial dysmorphisms and limb deformities. He has low set ears, flat nose, and small jaw. Breath sounds are decreased bilaterally. Ultrasound examination shows dilation of the ureters bilaterally as well as dilation of the bladder. Which of the following is the next best step to confirm the diagnosis of the patient? A. Chest X-ray. B. Nasogastric tube insertion. C. Voiding cystourethrogram. Or D. Karyotyping. So this newborn male is presenting with Potter's sequence. He has irregular breathing, is in respiratory distress due to pulmonary hypoplasia, and has limb deformities and facial abnormalities due to oligohydramnios. Ultrasound exam shows dilation of the ureters bilaterally as well as dilation of the bladder, characteristic of posterior urethral valves. This makes C, voiding cystourethrogram, the correct answer. Recall that the method of choice for diagnosing posterior urethral valves is voiding cystourethrogram, where dilation of the prostatic urethra will be evident. On ultrasound, a thick, dilated bladder and bilateral hydronephrosis is characteristic. The first-line treatment for posterior urethral valves is valve ablation, which relieves the obstruction and allows urine to flow from the bladder to the urethra. Now let's see why other options are incorrect. Option A, chest X-ray, will reveal pulmonary hypoplasia and will explain the symptoms of respiratory distress. It will not reveal the underlying cause, though, and therefore is incorrect. Option B, nasogastric tube insertion, is helpful to diagnose patients with esophageal atresia, commonly associated with tracheoesophageal fistula. Tracheoesophageal fistula is associated with polyhydramnios, not oligohydramnios, during pregnancy. Finally, option D, karyotyping, will confirm chromosomal abnormalities, which are associated with facial and limb abnormalities. But the combination of these features, along with the bladder and bilateral ureteral dilation, is highly characteristic of urinary tract obstruction due to posterior urethral valves. This makes the correct answer C, voiding cystourethrogram. And that concludes the section.